Hi, good evening everyone. Myself Dr. Harish Malapura Maheshwarappa. So I am one of the consultant in critical care medicine. Today I am going to elaborate a bit on general management of stroke patient in intensive care unit. We know that major pool of patients which come to critical care unit in terms of some neurological deterioration, they belongs to stroke, whether it may be a ischemic, hemorrhagic stroke or post-trauma stroke, or it may be a subarachnoid bleed. So today I'll just give some overall picture. So what are the importance of management of the stroke patient in relation to intensive care unit? Because it's very important, the long-term outcome of any patient who had stroke depends upon an integral intensive care support. So if you see the data, so near about 15 to 20% of the stroke patient require intensive care unit admission. About 5% of acute stroke patient require intubation and mechanical ventilation. So the outcome, so 30-day mortality, like 50% they are going to survive at the end of 30 days, and it comes down to about 30% at the end of 1 year follow. So it means the therapy which we are going to consider in intensive care unit is going to have both short-term and long-term impact on the overall outcome, so particularly mortality. So again, is keeping a neurointensivist or like keeping the patient particularly in neurocritical care unit with an intensivist is going to make any difference? Are we having any evidence on that? So there are lots of data available. So presence of an intensivist associated with improved clinical outcome. So there are multiple studies, pooled data definitely shows an intensive care unit, so approach will have an overall improvement in terms of mortality and morbidity in stroke patients. So again, which are the patients which require ICU admission? So all the patients we need to keep them in intensive care unit, or particularly some indications are there. If you see large space occupying hemispheric infarct or space occupying cerebellar infarct, basilar artery thrombosis, septic embolic infarction secondary to bacterial endocarditis, stroke associated with post cardiothoracic surgery, or stroke which are related to some interventions, okay, maybe like angiography or some other vascular intervention. So these are the patients particularly they need ICU admission. Then the patients whom we have done intervention for the stroke, so we have done some neuro intervention like thrombolysis or some mechanical thrombectomy. These are the patients whom we need to particularly keep in intensive care unit. So again, why intensive care unit? Okay, so there are some other than like brain related causes which can have some detrimental effect. It's not like so any of the stroke has happened, so we have to consider some extracranial causes which can have impact on the overall outcome. So it may be airway related, like airway obstruction, spasm, so pooling of secretion, hypoxemia, hypercapnia, hypertension, which may be associated with pain, agitation, coughing, straining, okay. If there is an obstruction of some sort of the venous drainage because of jugular venous obstruction, because of some neck compression, pneumothorax, abdominal distension, fever, or if you give some hypoosmolar therapy. So all these are the extracranial causes which are going to have an impact on the overall outcome of the stroke patient. So all these things we can manipulate in a favorable way if you keep the patient in intensive care unit. So coming to one by one. So I told airway related. So patient with a stroke can have compromised airway because of some particular reason. So the stroke, if it occurs in the brainstem, definitely there is a loss of control over the respiration, swallowing, coughing and all. So they are going to require some airway support. So overall there might be diminished like GCS. So with the suppressed gag and cough reflex, they need some support for the protection of airway. or it may be some complications like they already have aspiration, or if they are having some pulmonary embolism or pulmonary edema because of subarachnoid hemorrhage, there is something called neurogenic pulmonary edema. These patients, they require some sort of airway support to provide adequate oxygenation. Again, like next move on to other aspect is blood pressure control. Okay, we know that there is something called core and penumbra when it comes to ischemic stroke. So core is the part which already damaged, we can't do much further. So penumbra is the one which is having a susceptibility for the recovery if you maintain adequate perfusion pressure. So it's very important to protect this penumbra and protect this without any secondary brain injury. So again, what is the guideline tells? So if it is an ischemic stroke, keep the BP more than 220 by 120, or you come down on the blood pressure if there is any target organ damage. So what are the target organs? Like the patient is showing some sort of myocardial infarction or ischemia picture, aortic dissection, or if he is having a congestive heart failure, then we need to bring down the blood pressure by about 15% from the baseline to prevent all these end organ damage. Otherwise, our target, so don't bother to decrease the blood pressure if it is up to 220 by 120 millimeters of mercury also. So we know that, okay, why it is important? The area, ischemic penumbra, it is a perfusion dependent area. So the patient is going to have worsened symptoms at lower blood pressure, and automatically there is a possibility of improvement in the symptoms if we maintain an adequate blood pressure. So again, move on to how we can maintain the normal blood pressure as expected in stroke patient. So we have to keep them with the achieved good euvolemic condition. They are already on some sort of outpatient based antihypertensives. You have to stop all those things. So you can consider infusion of norepinephrine to improve the mean arterial pressure. So MAP and systolic blood pressure goal should be 20 millimeters of mercury more than the point at which the patient is going to have some symptoms. That should be our approach to maintain the blood pressure in ischemic stroke patient. So next move on to other important support which we have to consider is cardiovascular support. Why it is important? See, near about 70% of acute stroke patient, they are going to have some sort of hypertensive crisis and all. So other important thing is atrial fibrillation. Either atrial fibrillation may be the cause for blood clot in the left atrium and it get dislodged and it leads to stroke, or some patient with ischemic stroke can manifest the atrial fibrillation. So other thing is bradyarrhythmias, tachyarrhythmias, including third degree AV block, ventricular fibrillation, especially can happen in a patient who is having hemispheric stroke involving right insular cortex. So these are the areas they particularly need some sort of cardiovascular support. So again, when it comes to atrial fibrillation, so it is very important. So we have to address immediately some modifiable risk factors. So under 3 headings, okay, one is rate control, rhythm control, and when to consider anticoagulation for chronic AF. So our goal for rate and rhythm control to give some symptom relief so that we can reduce the further hospitalization. When we consider anticoagulation, so our aim is to prevent further thromboembolism. In the same time, they should not get any increased bleeding risk. So coming to what are the risk factor which we can modify. Suppose, like I told, if you keep the patient in intensive care unit, obviously we can consider some sort of reversible risk factors like fluid overload, hypoxemia, hypotension, anemia, acid-base abnormalities, electrolyte disturbances, or some overall disease severity. We can take care in terms of reversible or modifiable risk factor for atrial fibrillation. There are some non-modifiable risk factors which we can't help, like advanced age, so obesity. All these things immediately we are not able to do anything. If they are already having a coexisting comorbidities like ischemic heart disease, or if they are on some medication which can trigger bradyarrhythmia and all, we can't help immediately. So again, like what to do for the atrial fibrillation? The debate is whether we have to go for the rate control or rhythm control. So lots of trials showed. So namely, for RAISE AF CHF trial, so no mortality benefit from a rhythm control strategy compared to rate control strategy. So if you achieve an adequate rate control, it's more than enough in terms of overall mortality benefit. So particularly in elderly patient and those who are asymptomatic, so you can just hold on with some sort of the rate control, no need to go for rhythm control. So when to consider rhythm control? If the patient is symptomatic, okay, so even after achieving the rate, so then it's very important to go for sinus rhythm on a long term goal. So otherwise we are happy with the adequate rate control. So $1 million question is, what is adequate rate? So I told we have to control the rate adequately, but nobody knows what is the adequate heart rate in a patient who is having atrial fibrillation with stroke. So control of the rate is important both at rest and exertion, that we have to remember. Achieving a ventricular rate somewhere between 60 to 80 beats per minute at rest and between 90 to 110 to 115 during moderate exertion is considered as adequate rate control. So if it is within that range during the rest and some moderate exertion, it is fantastically okay to accept that rate. So this is the overall medication selection for atrial fibrillation. The key factor is the ejection fraction, that is the left ventricular contractility. If the ejection fraction is less than 40%, or if they are having some sort of signs and symptoms of congestive heart failure, we have to be very careful when we select beta blockers. We can go for very small dosage to achieve the rate control. If the ejection fraction is more than 40%, then we can use calcium channel blockers like diltiazem. It's a very fantastic drug to control the rate, or verapamil, or we can use beta blocker. So then suppose calcium channel blocker, beta blockers are not helping, then we can consider digoxin with a particular monitoring of electrolytes to keep the rate less than 110. So hand in hand, we have to consider not to create any bad bradyarrhythmia and bradycardia. So we have to look for the echocardiography, look for the LA clot. So then appropriately we have to consider anticoagulation in the meanwhile. So this is the overall overview on the management of atrial fibrillation in stroke patient. So again, so can we use some risk stratification score to predict adverse effects of anticoagulation, the need of anticoagulation? We know that there are some scores like CHARTS-2 score, CHA2, DS2, VAS score, AS-BLED score and all those things. But the problem is all these things are having a good validation in outpatient and ward area, but in critically ill patient the validation is not happened, okay, because one of the risk factor they included stroke. So in all the three stratification score they included stroke and post thrombolysis as one of the risk factor, but so there is no good validation in ICU patient for all these risk stratification scores. Again, other important thing which we have to consider managing particularly in ICU is stress cardiomyopathy. So because we know that stroke is going to trigger catecholamine release and cytokine surge. So ECG are sometimes abnormality, we are going to find all sort of ECG abnormality. In about 20 to 30% of the patient there is a rise of troponin, particularly in subarachnoid bleed, okay. So they can give ECG findings to mimic as an acute coronary syndrome with all STT changes. There might be ST segment elevation also. There might be many times cerebral troponin elevation also. So there is something called stunned myocardium with some wall motion abnormalities, which is going to be reversible and usually resolves within over 1 to 2 weeks. So they can have pulmonary edema, which I already told. There is something called neurogenic pulmonary edema with severe hypoxemia in about 10 to 20% of the patient. So all these because of stress cardiomyopathy. They can have something called Takotsubo cardiomyopathy or broken heart syndrome, which is catecholamine surge related. If you done angiography, you are going to get negative angio. There is no thrombus in the coronaries. It is all related to catecholamine surge. So then other important thing which we have to consider monitoring and managing appropriately is blood glucose. Many patients, they are going to have hyperglycemic response if they are having a stroke. That is because of non-fasting state or impaired glucose metabolism from stress state. So it's going to have the worst outcome. You have to remember, so most of the time it is a fluctuating blood glucose which is going to have a bad impact than like high or low blood sugar, but both are bad. So someone who is having a fluctuating blood sugar level, so increased risk of intracranial bleed after thrombolysis, larger increase in the MRI infarct volumes. So many of the guidelines suggest you keep a blood sugar in between 140 to 180 milligram per deciliter. That's more than enough. So no need to go for tight control. But there is one ongoing trial that is called SHINE trial, Stroke Hyperglycemia Insulin Network trial. So trial is currently enrolling the patient with intensive glucose control between 80 to 130 versus standard control, that which I told 140 to 180. We have to wait for the result of this trial, but current existing knowledge, take home message on blood glucose control, we have to maintain somewhere in between 140 to 180. Avoid fluctuating blood sugar. So it's not like just if they are having high or low, avoid very bad fluctuations of blood sugar level in critically ill patient. So other thing when it comes to managing patient in ICU is like fever in a patient who had a stroke. Okay, we have to evaluate any new onset of fever in a systematic way. So we have some infectious causes and non-infectious causes, because if you remember in subarachnoid bleed patient, so because of the lysed product of RBCs, which is going to cause some sort of thermostatic variability set point, they can have fever, dyselectrolemia, autonomic instability and vasospasm. So that is a non-infective cause of fever. Don't jump on giving antibiotic for all the patients who are going to have the fever. It may be a central fever also. How we can evaluate? Suppose if the patient had like fever more than 38.3 degrees Celsius, review all the possible causes, whether it's an infectious, non-infectious. Draw 2 blood culture sets. Okay, if the patient is immunocompromised, do one chest x-ray if the patient is ventilated and start antibiotic according to the antibiogram. If the patient is not immunocompromised, okay, is not neutropenic, not post chemotherapy, not retroviral disease and all, we can wait, okay, for a couple of hours before jumping on giving the antibiotic. So what are the infectious causes? If the patient is having a endotracheal tube, Foley's catheter, central line, it may be related to bed sore, or if the patient is having diarrhea, it may be simply because of Clostridial difficile. Many times stroke patient, they are going to have the Ryle's tube, which may be because of sinusitis, or the patient is having thrombophlebitis. These are some inflammatory related fever, means like thrombophlebitis and all, so which may not be infective. But if the patient is having central line, endotracheal tube, you have to suspect infective cause for the fever in stroke patients. Again, other important thing is like seizure prophylaxis. Do we recommend like prophylactic anticonvulsants? Answer is no. Okay, if the patient is having active convulsion, give the anticonvulsants. Otherwise, no recommendation for prophylactic antiepileptics. So seizures occurs in about 5 to 15% of intracerebral bleed patient, usually in the first few days of hospitalization. Sometimes we need to do continuous EEG, because near about 8% of the patient, they can have something called so non-convulsive status epilepticus. Then we need particularly EEG to start or to do some sort of burst suppression in patients who are going to have electrical seizure activity in their brain. So maintaining cerebral perfusion pressure, it's very important. We need cerebral perfusion pressure at least more than 60 to 65. So avoid hypotension or sudden drop in blood pressure. So modalities that lower the intracranial pressure by decreasing cerebral blood flow should be avoided. So if your goal is to decrease the cerebral like intracranial pressure, don't use any medicines which are going to compromise the blood flow to the brain. So avoid hypovolemia, keep them euvolumic, preferably with a crystalloid. So patients with distributive shock might require norepinephrine, particularly if they are having a spinal shock or septic shock. In patients with cardiogenic shock, we can consider dobutamine or epinephrine to maintain the adequate cerebral perfusion pressure. So move on to osmotherapy. So one important aspect, we don't want increased intracranial pressure. So acute effect, we can use 200 ml intravenous bolus of 20% mannitol or 100 ml of 3 or 7.5% hypertonic saline as an osmotherapy to decrease the cerebral edema, to decrease the intracranial pressure. Subacute effect, so up to 4 times we can use 250 ml of 10% glycerol per day, each infusion over a period of 2 hours. But the problem is, so they can have very bad hemolysis and raised LDH and all. So negative side effect of long-term osmotherapy: rebound cerebral edema if there is a breach in blood-brain barrier, dehydration, shrinkage of normal brain tissue, facilitating the risk of like cerebral herniation and all, electrolyte imbalance, particularly if they are on mannitol, they can have acute kidney injury, raised serum osmolarity, hypervolemia, particularly in patient if they are having congestive heart failure. So they can have acute rise in like hypervolemia with pulmonary edema. These are the adverse effects of osmotherapy. So when it comes to osmotherapy, do we have like any comparison data like 3% saline versus mannitol? So in terms of outcome benefit, both are equally good. But if the patient already having existing acute kidney injury, so it's prudent to use 3% saline. In patient with volume depletion, go for 3% saline, so as an option for anti-edema measure, because like it can act as one of the resuscitation fluid also. So next, like the routine care which we practice in intensive care unit, like in other general patient, we have to be very careful. Like putting a central venous cannula, it may cause increase in intracranial pressure. So because of decreased venous drainage, you have to be very careful. So it is very stressful during the phase of laryngoscopy and intubation. That also you have to keep in mind. You have to take appropriate care without causing any sudden increase in intracranial pressure. Use short-acting agents like propofol, etomidate, which have good hemodynamic stability, particularly etoposide, in conjunction with rocuronium when it comes for the purpose of intubation. So we can consider on the go, there is a concept called analgo sedation. At the highest level of opioids, they can give some good sedative effect with a BIS monitoring as advised to maintain good sedation without causing any problem with intracranial pressure. So big question is how much PEEP, positive and expiratory pressure, we have to keep when we are ventilating a patient with increased intracranial pressure. We have to remember whatever the PEEP we are going to apply during controlled mechanical ventilation, the transformation of the PEEP into the intrapleural pressure, the impact of increase in intrapleural pressure secondary to PEEP, so depends upon the compliance of the lung. Don't think PEEP is always bad in any patient with intracranial pressure increased. So it depends upon, so is the PEEP is going to have some hemodynamic bad effects, or is the PEEP is going to improve some sort of oxygenation. So all these things you have to consider. Don't nutshell, so take like PEEP is bad in all the patients with intracranial pressure increased. So you have to weigh all these risk and benefits when you apply the positive and expiratory pressure. So then again, timing of tracheostomy, don't think okay early versus late. Sometimes it may not apply in a patient who is already having a stroke. If you consider the patient is going to require prolonged ventilation, so is not able to protect his airway, you can consider early tracheostomy, which helps in some sort of good toileting, which may help in reducing the incidence of ventilator associated pneumonia, may not have overall impact on the mortality. Definitely it helps in cutting down the sedation, good hygiene of the oral cavity. So next, coming on to hyperventilation, so to reduce the intracranial pressure, so what is the rationale? You have to remember, so serum and CSF alkalosis induces cerebral vasoconstriction. So and reduces the cerebral blood flow when you create hyperventilation and try to wash out the carbon dioxide. The problem is too much washout of carbon dioxide leads to vasoconstriction, which can cause compromised blood supply to the brain. So you have to remember, so it is only transient effect. So temporarily we can give induced hyperventilation and hypocapnia as a cerebroprotective measure. So, but the problem is when the patient is going to have a respiratory alkalosis, which is going to shift the oxyhemoglobin dissociation curve to the left, which means oxygen is not going to dissociate it at the tissue level. So one way we are compromising the blood supply by causing vasoconstriction because of hypocapnia, and the other way which is going to decrease the release of oxygen at the tissue level. So both are very bad. So maybe somewhere around we can consider keeping the carbon dioxide 35 around, so as a transient immediate measure to prevent the cerebral herniation, but not more than 4 to 6 hours. Suppose if you want to keep the carbon dioxide in the range of 32 to 35 for more than 4 to 6 hours, then you have to use some more modality of monitoring like jugular venous oximetry or brain tissue partial pressure measurement for accuracy of decreasing the cerebral pressure without causing any problem with the blood supply to the brain. This is a stepwise approach how we can consider decreasing the intracranial pressure. First, like take care of their airway, okay, so maintain the normocarbia, increase their sedation level, so avoid the agitation, so that which can cause increase in intracranial pressure. So if required, we can consider ventricular CSF drainage. So hyperosmolar therapy, I told mannitol 3% saline. So induced hypocapnia if there is impending cerebral herniation. So finally we can consider some sort of induced therapeutic hypothermia, barbiturate coma, decompression craniectomy, and also these are the modalities which are available to decrease the intracranial pressure. So again, so coming on to one more important aspect of ICU care, that is the nutrition. There is a high incidence of prevalence of malnutrition. There are lots of studies. So this is the systematic review of 18 studies which showed the frequency of malnourishment ranged from 6 to 62%. So wide range of the incidence of malnourishment in stroke patients. This variation is because difference in timing of assessment, so inclusion criteria including different types of the stroke. It may be ischemic versus hemorrhagic stroke, comorbid medical condition, stroke complications. So non-uniform nutritional assessment method. That's why we have the incidence range somewhere varied between 6 to 62%. So you have to remember malnourishment is going to have a poor overall outcome in terms of ischemic and hemorrhagic stroke patient. Malnourished patient with stroke experience more intense stress reaction, show higher rates of bed sores, higher rates of urinary tract and respiratory tract infection like pneumonia, ventilator associated pneumonia, longer duration of hospitalization, higher mortality. No doubt we have to give much importance to nutrition therapy when it comes to stroke patient in critical ill patients. Again, you have to assess, there is something called screening for speech and language therapy. Okay, that is called SALT assessment. You have to assess for dysphagia, okay, in patients who are going to have higher stroke risk associated pneumonia. So 1% increase in pneumonia risk for every day delay in assessment of speech and language. But remember, if you delay assessing the risk for aspiration and speech and language, the pneumonia risk is going to be increased by about 1%. So it's very important you have to consider them for SALT assessment. Then you have to appropriately cover them for the nutritional therapy. So again, coming on to one more important like factor you have to consider when managing a stroke patient in ICU, that is dyselectrolemia. So hyponatremia is the most common dyselectrolemia which can happen in about 30% of the patient. So most frequently in between 4th to 10th day of ICU admission. So it is more common in patients with subarachnoid bleed. They can have syndrome of inappropriate antidiuretic hormone like SIADH or cerebral salt wasting. So both are very different. So SIADH presents with euvolemia or hypervolemia, but cerebral salt wasting syndrome, it is going to be hypovolemia. They are going to have increased urine production. But if you done any urine analysis, SIADH and cerebral salt wasting, they are going to have increased urine osmolality, increased urine sodium, low serum osmolality and low serum sodium. How we can differentiate? It is the only volume status which tells if they are euvolemic or hypervolemic, it move towards SIADH. It is not like cerebral salt wasting syndrome. So avoid excess of water intake in SIADH versus replace the volume with isotonic or hypertonic saline in a patient with cerebral salt wasting syndrome. So many times both SIADH and cerebral salt wasting syndrome may have some existing overlap. So particularly you have to avoid hypotonic fluid, particularly dextrose based fluid and diuretic, as it may promote cerebral ischemia. So that's about managing dyselectrolemia, particularly hyponatremia. So the one complication we have to keep in mind in ischemic stroke post thrombolysis is hemorrhagic conversion. So hemorrhagic conversion can happen with or without using thrombolytic agent. So there are some risk factors when a patient had some hemorrhagic transformation. You have to consider pre-existing risk factors like size of the infarction. If it is a cardioembolic stroke, they are going to have more chance for hemorrhagic conversion. High NIHSS score of the stroke, hyperglycemia, as I already told, which increases the risk of hemorrhagic conversion, low total cholesterol and LDL levels, thrombocytopenia. These are the particular risk factor when it comes to conversion of ischemic stroke to hemorrhagic stroke. Again, post thrombolysis, you have to do some protocolized approach. Hourly, you do the GCS monitoring for initial 24 hours. So no antiplatelet or anticoagulation, particularly in first 24 hours. Keep the blood pressure less than 185/100. Avoid unnecessary lines and catheters. If you suspect any sort of neurological deterioration in the initial 24 hours, immediately get an imaging. It may be worsened neurological, new onset of neurodeficit or pupillary changes, or if they started complaining headache, immediately get a CT head. So how to manage if the patient had hemorrhagic conversion of ischemic stroke after thrombolysis? So there is no universal protocol exists. What we follow is stop infusion of any thrombolytic agent if it is ongoing. Immediately get a CT. In the same time, send fibrinogen, PT, APTT, INR and complete hemogram. So order for grouping and cross matching. So order 6 to 8 cryoprecipitate or FFP and 6 to 8 units of platelets. Consider protamine if there is a prolonged APTT. So we can use activated factor 7 once you satisfied certain criteria. When we are having some like waiting period for cryoprecipitate or platelet, so immediately consult neurosurgical reference. They might require some sort of decompression. So these are the things which we can consider when the patient with the ischemic stroke post thrombolysis have some hemorrhagic conversion. So a bit on something called malignant MCA infarct. Okay, despite medical therapy, if they have a malignant middle cerebral artery infarct, mortality is up to 80%. So most effective treatment in malignant MCA infarct is decompression craniectomy. So there are three major trials I just want to mention here. One is Destiny, Decimal and Hamlet trial. The pooled data of these three trials, the overall outcome which shows in terms of functional improvement, if you consider decompressive hemicraniectomy within 48 hours, so versus the regular medical management, there is an overall improvement in mortality and functional outcome. So this is the inference of these three trials in terms of decompressive craniectomy in a patient who is going to have malignant MCA infarct. Again, other general care we have to continue in ICU. Like what we do for other patient other than stroke, we have to consider head and elevation, so feeding, analgesia, sedation, stress ulcer prophylaxis, so spontaneous breathing trial, bowel regimen. So we have to take care of indwelling catheter. We have to consider removing the catheter or the lines when there is no need, de-escalation of antibiotics. So that we call it as fast AX BD, that we need to continue as equal to that of other general ICU patient. So there are some prognostic indicators why we are going to have a stroke patient which can have poor outcome. So if they have, in ICU particularly, if they have persistent accompanying fever, hypotension or severe hypertension, so hypoxemia, hyperglycemia or hypoglycemia, total anterior circulation stroke, if 50% of the brain tissue is dead, so pontine hemorrhage, low GCS score, so stroke with heart failure, severe hemiparesis, these are some prognostic indicator to predict a particular patient with a stroke may not do well in his near future. So coming on to like end of my lecture, so stroke basically needs a multidisciplinary approach which start from the pre-hospital care, emergency room, and in coordination with the radiology, stroke unit, so intensive care unit, particularly if they have some indication to shift to the ICU, so which require some acute care. So once they came out of the ICU, they require chronic care, that is neuro rehabilitation. So all these things are integral part of stroke, so which helps in improving the overall mortality and morbidity. Thank you all. So watch my YouTube channel to get more and more evidence-based lectures on critical care medicine, emergency medicine and anesthesia. Please subscribe to my channel. You just Google Dr. Harish MM in the YouTube, so you'll get an idea about my channel. Thank you all.